Hello everybody, this is Dr. Medicine RX here, and in today's topic we'll be discussing pheochromocytoma. I've really summed up the diagnosis part of it, but for the sake of completion, I'll give you some introductory points. So pheochromocytoma is basically a catecholamine producing tumor, and it is usually adrenal in origin. That is, it is usually present in adrenal medulla, but sometimes it can also be seen in extraadrenal sites, for example, organ of Zucker-Candle, and here it will be called as paraganglioma. Then coming to rule of 10%, which is really important, that it states that 10% of these pheochromocytomas are going to be malignant, 10% will be bilateral, 10% are going to be familial, and 10% will be seen in children, and 10% of these are going to be extraadrenal. If metastasis is associated with this pheochromocytoma, it is definitely going to be a malignant tumor. And if it is a familial condition, then it is usually seen associated with other familial conditions such as neurofibromatosis or Sturge-Weber syndrome or Mentor syndrome. But most of these are going to be sporadic because remember, 10%, only 10% of these are going to be familial. Now, guys, coming to the presenting features, the question how it is going to be framed, and what are the features that we can expect, are that the most common symptom is going to be headache. That is, a patient is going to come to the outpatient department mostly with the complaint of headache. So it is the most common presenting feature. Then the most common feature, that is when you go ahead and check the vitals, it is going to be hypertension. The screening test for these pheochromocytomas, it is going to be the estimation of 24 hours urinary VMA. VMA is nothing but vanillyl mandelic acid. And the most sensitive test, it is going to be the estimation of plasma fractionated metanephrines. These are nothing but the byproducts of catecholamines, that is noradrenaline, adrenaline, etc. So these catecholamine tumors, pheochromocytomas, that is what we call them, are mostly going to be producing noradrenaline. Then coming to the investigation of choice, it is definitely going to be MRI over contrast enhanced CT scan. On MRI, you'll see a light bulb sign, that is the tumor. It is going to be appearing as bright white on T2 weighted MRI. And if the tumor it is associated with any metastasis, or if it is extraadrenal in origin like we discussed, then the investigation of choice becomes gallium 69 dotatate scan. Now coming to the treatment point of view, it is definitely going to be the most important aspect, because first we go with the conservative management. That is, we prefer giving drugs. Then the drugs that are usually given are alpha blockers such as phenoxybenzamine. If the patient also has tachycardia, then we give beta blockers. Always remember the most important point here, it is going to be that alpha blockade is followed by beta blockade. Then coming to the surgical approach, it is going to be laparoscopic adrenalectomy. And if the tumor is really large, that is, we can't go with the laparoscopic approach, we do the open procedure. That's all for this video. I hope I was able to provide some important and crisp points. Thank you, and do follow Dr. Medicine RX for more such content.